Okay, well, while we're waiting for people to sign on, I'll just introduce our speaker and the topic. So our presentation today is related to what we discussed at the previous faculty meeting, fatigue risk management and the hidden curriculum. And this is being presented as it was identified by our internal review last year as one of the areas we needed to improve on, and of course is really an important part of the program. There are strategies that have been and are being developed for our residency curriculum through PGME and in our program, for example, the Resident Safety and Wellness Policy. So this will tie in nicely with that. And I'd like to thank Russell and Susan for bringing this topic forward for faculty development, really important for all those reasons. And I'm really happy to have Dr. Lynette Bowes speak to us about this today. Dr. Bowes and her colleague, Dr. Megan Burke, have spearheaded this work in their pediatrics program. Dr. Bowes graduated from Memorial in 1995 and completed her pediatric residency as well at Memorial, and then went on to complete a subspecialty training at Sick Kids in Toronto, and since 2001 has been a pediatric hematologist oncologist at the Janeway. She also tells me in January 2019, she became the Pediatric Residency Program Director, which she is finding a very exciting challenge. We can probably all relate a little bit to that. She's also been an accreditation surveyor for the Royal College for several years. And through both of these roles has led her to have an interest in fatigue risk management. Also want to let everybody know that this session is being recorded and will be shared with the streams. And I will pass it over to Dr. Bowes. Welcome.
Thank you. Well, I hope this meets sort of your expectations with respect to faculty development. The presentation I'm going to give today is largely based on a gram rounds that we presented to our own faculty in 2022. As indicated, Megan Burke is actually our fatigue risk management lead for our residency program, but she's on maternity leave right now. So a lot of the strategies that we're working on developing are to her credit for sure. All right. Hopefully I don't have any technical difficulties. Okay, so the objectives of this session are really to talk about how fatigue can potentially pose a risk to not only the resident, but to the workplace and to patient safety, and describe what our roles and responsibilities are as not just residents, but as residency programs and from an organizational point of view. And then hopefully, which sounds like you already have done, to reflect on what we can do locally to develop some strategies to decrease the risk of fatigue in terms of patient safety and resident wellness in particular. So I'm sure a lot of us are all familiar with why we are all called residents, but I found this a little bit interesting and a nice way to kind of maybe introduce how we got where we are in terms of resident work hours and fatigue. So in Canada, the first medical education program opened up in 1823 in Montreal. And eventually became the first faculty of medicine in the country when it incorporated into McGill College in 1829. After graduation, you could go straight into medical practice, or you could move into the hospital and become a house officer. So house surgeons or physicians were hired to live in the hospital and provide service around the clock, 24/7. And here's where the term resident evolved from, because doctors actually resided at the hospital. Residency programs were developed later. So the first accredited, residency, the Royal College was first established in 1929 with the first accreditation guidelines, which were actually the responsibility of the hospital at that time, developed in 1945. The first time an on-site accreditation survey ever occurred was in 1963. And that was the first time the word program was officially included in the discussion of residency training. So a more formalized, described process didn't really exist prior to the 1960s. In 1960s, the first intern resident organization was also formed, and significant wage increases were negotiated for the first time. And of course, it was initially called CAR, and now we know it as RDOC. So until the mid-1950s, residents were actually employees of the hospital, so not formally associated with a university, and were paid by receiving room and board, as well as a small stipend for compensation. It wasn't until 1975 that the Royal College accreditation was actually transferred to the residency program from the hospitals to the university. So up until that time, it was a hospital responsibility. So accreditation has been part of what we have recognized as attendees of residency programs and program directors and planning committees for a long time. But in 2018, a new set of standards were introduced and a new framework for accreditation for residency programs. It's called CANERA, and as of 2020, all residency programs undergoing accreditation are evaluated using this new set of standards for residency programs. So these were adopted through the Royal College, as well as the College of Family Physicians of Canada and the College of Medicine in Quebec. As you may know, the pediatric program had an external review in 2021, and we were evaluated based on the CANERA standards. And because of that, had an opportunity to develop a fatigue risk management approach prior to that. So there are 9 standards in the new CANERA framework. Standard 5 is specifically about safety and wellness of the residents. One of the main requirements is that residency education occur in a safe learning environment. And the things that each residency program has to demonstrate as an indicator that they're meeting that requirement include having policies and processes around fatigue risk management, but also to demonstrate that residents are supported and encouraged to exercise discretion and judgment regarding their personal safety, including fatigue. So when did we start talking about fatigue risk management in healthcare? So in the late 20th century, so the late 90s and early 2000s, resident duty hour changes initially came into place. And when I started my residency in 1995, it was not long before that where residents were allowed to go home at noon as opposed to staying for the full day the following day after your call. Some of these changes were initiated by a very important legal case in New York State, from which a law called the Libby-Zion law was developed. So Libby-Zion was an undergraduate university student who presented to an emergency room with flu-like symptoms and died of a cardiac arrest later that evening. In the end, it was felt that she had serotonin release syndrome, but she was cared for by a PGY1 resident and a PGY2 resident who had worked very long hours and were responsible for 40 inpatients, as well as patients that were presenting to emerge. Libby's father was a lawyer who worked for the New York Times, and they had a very public criminal and civil law course, over which time the 2 residents were actually charged with 38 counts of neglect, and the case was tried as a murder case in New York. After that, a law in New York State came into place called the Libby-Zion law, which limited resident work hours to 80 hours a week. So a very important part of the development of reducing the number of hours that residents could work. Over the next 10 years, there was increasing attention to regulation of medical resident duty hours. Unfortunately, despite changes to those hours in both the US and Europe, the anticipated decrease in medical errors didn't happen. So they felt that that was likely due to perhaps more patient handover having to occur because of the shorter shifts, lack of continuity of care, and ongoing poor trainee supervision. So because of that, people began to realize that it wasn't just the duty hours that were contributing to fatigue-related risk. So in 2013, the Royal College released a report and recommendations called Fatigue Risk and Excellence, and in an effort to develop a pan-Canadian consensus on resident duty hours. One of the main recommendations there was that a comprehensive approach to decrease fatigue-related risk should be developed and implemented in residency training programs in Canada. So 10 years ago, even though it's really only becoming a part of our accreditation standards now. They launched a fatigue risk management project in 2013. And then in 2018, they released a fatigue risk management toolkit. Which is available to all residency programs and leadership across the country through this website, www.residentfatigue.ca. And it's a non-prescriptive toolkit that allows you to develop a program-specific fatigue risk management policy as well as processes and strategies. So this is the website, and it allows you to download the toolkit, or you can use it obviously digitally, but lots and lots of resources in there, which I think most programs in Canada are using to help facilitate the development of their fatigue risk management plans. So the toolkit gives a great background describing what fatigue is and also has some guiding principles in terms of how to adapt and develop a plan for each residency program. So after the toolkit was released and had some success in terms of utilization with some pilot programs, the standards for accreditation which were released in 2018 were revised to include fatigue risk management. So that's how we got here to a place where we're needing to have a more informed discussion about fatigue risk management and how to mitigate for the risk. But what is fatigue? Well, I'm sure most of us have a pretty good understanding of what fatigue is. But in terms of the feeling of tiredness that is generally physical and mentally, it has features that can be concerning in terms of our practice of medicine. So not only does it make you sleepy, but it also can lead to compassion fatigue and emotional exhaustion. We all think about sleep deprivation and poor quality of sleep as being a main cause of fatigue, but there are many other causes of fatigue. Your mood, your environment, your social environment, as well as your workplace. So all kinds of things, including your diet, impact your fatigue along with your quality and quantity of sleep. So lots of things to think about in terms of what we can mitigate. So in terms of what makes you sleepy and what makes you, what is your influences your drive to sleep? So there are two main biological forces that are in play that affect your amount of alertness. So your circadian rhythm, which is your wake drive, which fluctuates throughout the day, obviously. I'm going to try to find my cursor. I have 3 screens open here. So obviously, when you awake, it increases over the morning, and in the afternoon, there's a little dip that I think we all recognize, with a slight increase until bedtime when it decreases dramatically. So we all have a low wake drive no matter what amount of sleep we have had from the hours of 3 a.m. to 5 a.m. So always a crucial time to think about in terms of what people call the witching hour, or the time when we're probably most likely to suffer from poor alertness. Conversely, our homeostatic drive is very much influenced by the amount of sleep we've had, whereas our circadian rhythm really isn't influenced by sleep debt. When we have a high sleep debt, our homeostatic sleep drive is even more pronounced during the night than it would even normally be. So it would increase throughout the day until we go to bed, and then as we sleep, our sleep drive should improve. But if we haven't had any sleep, obviously, it just progressively increases. So you can see in a person who has a sleep debt or has had no sleep, that the sleep drive can be quite intense when you also have a very, very weak wake drive. So it can be a time when your alertness is really quite impaired. I'm going to show you this short video, and I hope this works, okay, I'm going to just plug in my computer, because that would be bad. I'll just play this video. Let me know if you can't hear it.
Tired? We all know the feeling. Irritable, groggy, and exceptionally lazy. Chances are you slept enough last night or the past night. But what exactly is it? And more importantly, whoever can jump on it. While the very function of sleep is still debated by scientists, we do know that it's necessary to function efficiently and productively. After all, we spend 24 years of our lifetime sleeping, and it better be important. Researchers have tested how much is required each night by assigning groups of people to 4, 6, and 8 hours of sleep over extended periods of time. After 14 days, those with 8 hours of sleep exhibited attention lapses or cognitive issues. However, those with 6 or 4 hours of sleep showed a steady decline. In fact, after only 2 weeks, the 6-hour group showed a similar reaction time to a person with a blood alcohol concentration of 0.1%, which is considered legally drunk. The 4-hour sleepers suffered more, occasionally falling asleep during their cognitive tests. In both groups, brain function decreased day by day almost linearly with no sign of leveling off. Scientists have dubbed this cumulative effect as sleep debt. So can we recover from it? After a night or two of little sleep, studies show that the body and brain can fully recover with a few nights of good sleep. However, with long-term sleep deprivation on the scale of weeks to months, the recovery of cognitive function is much slower, requiring many more nights of quality sleep. On the timescale of months to years, it's unknown whether brain function can be fully repaired or if it causes permanent damage. Paradoxically, with chronic sleep deprivation, your sleepiness or how tired you feel does eventually level off, meaning that you become less and less aware of your objective impairment over time. So how long should you sleep? Well, most studies tend to show that 7 to 8 hours of sleep is the average ideal for humans. Apart from the cognitive issues, individuals who can consistently sleep less than 7 hours a night have an increased risk of heart disease, obesity, and diabetes, not to mention a 12% higher risk of death. On the flip side, studies have shown that while sleeping more than 8 hours does not impair brain function, it also carries.
So I think that video needs to come with a disclaimer, honestly, because I think every time I see it and every time I've watched that video with other people who have gone through residency, everyone's a little bit disturbed by the missing pieces of brain, which may not be recovered in someone with a chronic sleep deficit. But I think a lot of people also have been able to reflect and say, okay, perhaps I can identify with that. So as indicated in the previous slide, there are lots of causes of fatigue. Sleep is a big part of it, your circadian rhythm, the amount and quality of sleep, but also stress plays into fatigue. In terms of organizational things that can contribute to fatigue, so cultural things within the hospital, fatigue is not taken seriously, and this is where the hidden curriculum perhaps can play a role depending on the culture of the program that you're working in. Lack of support for napping at work, and then your workload. So how much time are do you have between your shifts? Are there enough people scheduled for your shift? Do you have multiple roles? How difficult is it for you to sleep when you're on call? So lots of different things contributing. So in terms of an organizational or program attempt to mitigate, sometimes the things that we can look at are inadequate rest time between shifts, shift scheduling and staffing. So these are things where we might focus some of our attention.
I think we may have lost you, Dr. Bose. Yes, I think the video is probably gone for all of us. Are you still there, Lynette? Not sure now. Still looks like she's logged in, but perhaps, Lynette, if you can hear me, perhaps if you try to log out and log back in again. Sorry, everyone. I guess while we're waiting for Lynette, any comments about the presentation so far? Any surprises or things that confirm for us about fatigue in residents and I guess in general? You can unmute if you like to make any comments.
Sure, I'll comment. I think the point about culture and hidden curriculum is a good one. Comments that I often hear from learners or in their feedback are, you know, this is the way it's always been, or we were told we just had to kind of get through it and get to the other side. So, but I see we've got Dr. Bose back, so I'll hand it back to you. I'll hand it back to you.
Sorry about that. I think my power bar inadvertently got turned off.
It's okay. These things happen. I'm telling you, it's very common. But welcome back.
My apologies. Okay. So what are the effects of fatigue? What aspects of our lives can be impacted? So whether you're currently a resident, previously a resident, or involved in any night shifts, or have other demands outside of your residency life, you can imagine, or I think we're all aware of ways and consequences of fatigue. So on a really concrete level, it can increase your risk of having motor vehicle accidents. So road users are at risk. Personally, we often have less energy to give to our social lives and to our families and friends. We might be more irritable. We might have decreased communication. And then to our colleague and patients, there also can be issues with decreased communication, decreased empathy, mental fatigue leading to decreased concentration, and then a direct risk to patients, which has been shown to lead to increased death or serious harm. This is information from Transport Canada, actually, and it specifically looks at the risk of having a motor vehicle accident, depending on how many hours you've been awake before driving. And so point 1 is the legal limit in Canada is 0.08. And after being awake 21 hours, you have a similar blood alcohol content to somebody who has exceeded the legal limit. After being awake for 24 hours, it's even more significant. So really hard to deny that we're asking resident doctors and sometimes ourselves, I suppose, as well, but not as commonly, to make decisions when their decision making is as impaired as somebody who is legally drunk. Not sure the general population would be comforted to know those statistics. So in terms of patient safety, there's been lots of studies and information generated about the risk to the patient in terms of fatigue in the physician provider. So some studies have compared 24-hour shifts to working 16-hour shifts, particularly at night, and also looked at the number of shifts per block. So in terms of medical errors, diagnostic errors, and intentional failures, all of those things increase, even when you compare 16 hours to 24. The incidence of fatigue-related adverse events in medicine resulting in patient fatality went up by 300% in people who were working more than 5 extended hour shifts per month. The risk of a fatigue-related error actually increases after 8 hours of duty and doubles after 12. So impressive to think about how many hours we expect resident doctors to function at and not cause patient harm. With respect to resident well-being, there's a higher incidence of personal injury with needle stick or other sharp injuries after 20 hours of work. As noted prior to, the risk of motor vehicle accident increases, so the risk is 2 times increased after 24 hours of work. And then the adverse effects on mood, difficulty starting or maintaining relationships, and being effective parents are known to be worse in people who don't get enough sleep. The number of hours of sleep correlates negatively with increased stress, how they rate their overall resident experience and learning. And we know you don't learn well when you're tired. So another thing to really think about, as you know, our discussion is often about how call is so important to learning. But if being fatigued really significantly impacts your short and long-term acquisition of knowledge and your higher order thinking skills, then maybe we need to rethink what the best learning environment is in terms of fatigue. Unfortunately, the research is not the type of research that we like to see in terms of being concrete, in terms of cause and effect. It's hard to do in vivo testing, obviously. Most of the experiments are sleep lab experiments and are not validated against medical tasks. And a lot of the other research is self-assessment surveys or retrospective reviews. The other thing that makes it pretty difficult is the complex nature of medical errors. So healthcare provider experience, of course, is going to be a factor, the clinical context, how much volume and acuity people are dealing with at the time, resource scarcity, and all other kinds of things that can impact the incidence of medical errors in addition to being fatigued. And then, of course, there's difficulties in measuring wellness when you're trying to measure how fatigue impacts wellness. It's also a blind spot for physicians because we don't like it to be pointed out that perhaps our decision-making is impaired. And being fatigued has been a part of residency education since there were residents living in hospitals. And I think as I came back on after my power outage, Russell was talking about that, you know, people's discussion about what they did and how residency compares to what they did going through. And I think, you know, every generation experienced that. And I remember as a fellow at Sick Kids, my staff person telling me about having to do 1 and 2 call throughout his whole fellowship. And now I was only having to do 1 and 4, and was that enough? And I think my response to him at the time was a question about how challenging he found breastfeeding doing 1 and 2 call, but I'm not sure I made my point. But I think this cartoon demonstrates it pretty well. You can do as much research as you want about fatigue risk as long as you come to these conclusions. And I think the conclusions historically physicians have wanted to see is that we're not impacted by fatigue in terms of our performance. So another important aspect of sleep deprivation and fatigue and working night shifts in a hospital is the effect of sleep inertia and our ability to perform. So sleep inertia is that time of grogginess right after you wake up. And it normally lasts about 30 minutes, but it can last up to 4 hours. But it negatively impacts our ability to react, to have complex decision making be accurate, and it affects our memory. And if you have a sleep debt, you're much more likely to suffer from sleep inertia. So how long it lasts depends on how long you've been asleep prior to being awake, and what sleep stage you were in, as well as your sleep debt and the time of day. So obviously, sleep inertia is going to be worse at night. And really, the purpose of sleep inertia is to allow you to go back to sleep after being awakened when you potentially should be asleep. So impairments during sleep inertia have been associated with significant workplace accidents, injuries, and fatalities, and I'll show you some specific ones as we move through the presentation. Another thing that we have already kind of talked about is the effect of fatigue on mood and irritability, how it can impact our communication, it can impact our patience and our enthusiasm, it can change how we interact or our rapport with others, and lead to complaints about professionalism and communication, which are a very large part of the type of complaints that the college receives in terms of resident physicians. And maybe they're a result of the fatigue that residents are experiencing to a certain extent. Okay, so we know what fatigue is. We know that it can cause us to make decisions that are not as good as they can be when we're alert. But fatigue is inevitable, so what do we do now? So given that fatigue increases the risk to the wellness of our resident, but also patient safety and outcomes, we have a duty as residents, but as leaders within residency programs, and then as health organizations to ensure that learners are able to work safely when fatigued, to minimize potential harm to the residents as well as their patients. So we have to acknowledge that they're tired, and then we have to decide how we're going to mitigate the risk to patients and to the resident. So outside of medicine, fatigue has been viewed as a safety hazard in other industries for a really long time, primarily aviation, but as well as in manufacturing, transportation, in the military, and they have a lower threshold in some ways for adverse outcomes, it seems, than we might have. So here are some really, I think, depending on how old you are, well-known industrial accidents and transportation accidents. So the Exxon Valdez oil spill in 1989, there was a third mate alone on the bridge in his 18th hour of work when that happened. The Air India flight occurred when both pilots' window of circadian low was, it was in that 3 to 5 a.m. in the morning. And there was actually a cockpit recording of the pilot snoring for 3 hours prior to the crash, and he was only awake for 20 minutes prior to the actual crash. And they felt that he probably was experiencing sleep inertia at that time, as he demonstrated a lack of perceptiveness, some automatic behavior, some flawed logic. So a real impact there. In terms of Chernobyl, the ship workers had been working for 13 hours. And then the Challenger disaster, some of the managers had only had 2 hours sleep prior to and had been on duty since 1 a.m. with the launch of the Challenger 10 hours later. So all kinds of demonstrated pretty significant industrial accidents that have been caused, at least in part by fatigue. So now what? So again, back to this toolbox, which is a really important resource for all residency programs in Canada right now. And I think we've demonstrated that it is an occupational risk in medical education. And I think now we can see that it's becoming a more accepted, more recognized, more talked about concept. And this was an article published in CMA, which talked about fatigue management needing to be a competency that's not only taught, but is modeled and mentored and then evaluated from medical student to practicing physician. So a real culture shift for some of us who really were not exposed to this kind of fatigue risk management mindset. So the 3 steps from the toolbox are to acknowledge that fatigue risk affects us all. And maybe for some of us, that is going to be the biggest challenge. And then to act. So use the tools that are available to foster change and then to adapt it to our residency programs and to integrate it into our culture so that we're constantly aware and thinking about fatigue and how we can mitigate the risk to our patients and to our residents. So fatigue risk management programs are aimed at individual management of fatigue. So we try to inform the residents that fatigue happens, fatigue risk is real, and to try to help them to discover strategies that might help them mitigate their own personal risk. And then training faculty and supervisors and staff with respect to policies and processes, but also the ability to integrate it into the culture of the organization and program. So some of the things that they suggest that residents can do is there are multiple self-assessment tools. Some of them we're using in the pediatric program on a pilot basis initially that help assess your fatigue prior to a shift. And then there are lots of tools and learning modules to talk about adequate rest, nutrition, and really how to manage your pre and post call life to mitigate fatigue as a resident. The University of Ottawa, and I'm sure you're probably aware, developed a really nice educational video for residents, which we have used now for 3 years in our residency program to talk to residents about fatigue risk and things that they can do to mitigate it as an individual. One of the big things, I think, is teaching people to recognize it, both physical symptoms and mood related symptoms that can help you identify fatigue, both in yourself, but also in your colleague, and potentially as supervisors in the residents that we're working with. So these are some of the things that we suggest to the residents. This is directly from the tool, and a lot of these things are mirrored in the educational video. So establishing routine, set the scene, all kinds of different things. I thought one of the suggestions was to wear sunglasses on your drive home so that the light doesn't keep you awake once you do get home. But we don't want to place all the responsibility for this on the resident. So again, some more tools that we're using to help educate and remind residents about trying to catch up on sleep and to do things that can mitigate sleep deprivation. So try to pay off your sleep debt as soon as possible. Don't get distracted by things that may delay going to bed. So don't stay up and do that presentation, or don't go get your groceries or do your laundry. Make sure that you prioritize sleep, which can be really, really challenging, especially if you have children at home or other personal responsibilities that often you need to catch up on post-call as well. They talk about the intentional use of caffeine, and I have done this for years, but didn't realize it was a strategy that I should publicize. But so they talk about proactively using caffeine, so having caffeine before a brief nap, so that by the time you wake up 20 minutes later, your caffeine has actually started to work and may make you a little bit more alert. And so there's some evidence around some of these strategies, and all of these are talked about in that educational video that our residents use. Being able to communicate fatigue to the team, being able to indicate that you're really tired so that you can have a colleague double check your orders. These are things that are resource intensive as well. So we can suggest that these things happen working in pairs. Well, that isn't practical a lot of the time. There are places in Australia where they actually wear a colored lanyard to indicate how fatigued they are, so that their team members know that their orders may need a double check. I think that's obviously a system that's in place for a while, and they're moved on to an elevated level of functioning, but something to think about in terms of, where we might be headed or how seriously we should take this. And if we provide a safe environment for physicians to identify their fatigue, then perhaps they would be able to indicate to a coworker that they're tired enough that they feel like their decisions need to be double checked. So barriers to change, probably mostly at an institutional level, and the pervasive attitude that a tired doctor is better than no doctor at all. And again, as indicated before, the nature of medical errors is quite complex, as is the whole definition of resident well-being and what our expectations for resident well-being are. And then the medical culture and the hidden curriculum around the fatigue paradox. So the fatigue paradox, I think all of us are familiar with the concept, if not the term. It's the whole idea that doctors somehow are not subject to the same effects of fatigue as the general population. So there was a study that looked at team perceptions of physician fatigue, and they were able to say that fatigue was problematic up until the point of impacting patient care. So what I mean by that is that they weren't unable to, or didn't, they weren't able to conceptualize or verbalize that their fatigue impacted patient care. And the themes that they identified in that survey was the idea of the physician not being fatigable, that this was something that physicians weren't able to talk about, that it was a blind spot. There was a lot of faith in the safety net, so the pharmacy and the nursing checks, and then also a minimization of fatigue-related events. So not full awareness of really the impacts of fatigue on physician performance. So I pulled this in a little bit. I normally don't talk about the hidden curriculum when I'm talking about fatigue risk management, but certainly that is a huge barrier. So I pulled this in from my hidden curriculum talk that I gave a few years ago. And so the hidden curriculum is really that culture of the environment that it's implicit. So influences and values of an organization that are not really on paper and may actually be opposing in terms of the things that we say we're going to teach, but what we actually do teach. And so we know that the hidden curriculum, these values, the implicit things that we teach residents really impact their ability to learn and to function. So we talked about the explicit curriculum, so that is the planned curriculum based on CanMed, CBME, milestones, EPAs, and then what we deliver, as opposed to the hidden curriculum, which is generally part of the informal curriculum. So is there a hierarchy in the seating? Who gets called upon in a teaching session? Who's in the room when teaching happens? All of those things that are not explicit, but are really a huge part of the culture of often different programs, even more than institutions. So just one moment now, I'll dismiss this. So I thought this was a really good way to demonstrate it. So we talk about interdisciplinary practice, collegiality, patient-centered care. So these are like part of our formal curriculum. But sometimes there's a hierarchy, talk among staff that is negative towards patients, eye rolling. And so this has sometimes a bigger impact than what we say are our values with respect to what we are trying to teach. Is patient care really family-centered and patient-centered when we're really focused on efficiency and trying to get through as many patients as possible? We talk about the value, how much we value patient care and empathy. And then a preceptor on ward rounds with a student routinely walks past a room where a patient is dying without commenting. So our behaviors really have a huge impact on what we teach our residents. So it can have a significant impact on what is learned. It has also been implicated in erosion of empathy, and that's well described in medical learners as they progress through training. You're much more empathetic at the beginning of training than you are at the end. And it can be mitigated if we can teach learners to recognize it and to consciously choose to reject the model behaviors that are negative. And I actually believe that our young learners are much better at that than perhaps I was or my colleagues were at that time. But they really do recognize behaviors that they don't want to imitate. And I think it's our responsibility to continue to make them aware and empower them to do that. But as a teaching faculty, we have a responsibility to be aware of it and to try to mitigate its effects by positive role modeling, and to not be a bystander when we see unprofessional behaviors in others. Great, I'm just going to skip through that. So one of the huge barriers to fatigue risk management is really making sure that as a faculty, we acknowledge that fatigue risk exists. So here's just a few things that we're doing at MUN-PED. So in June of 2022, we had Amy Robinson from CHEO come and give a grand round. So after the launch of the toolkit, or in concert with it, 2 programs in Canada were selected to develop fatigue risk management programs as pilot projects. And one of them was run by Amy Robinson, who is an adolescent pediatrician at CHEO. And the module that we used to educate our residents came from her pilot project. After that, Megan took over the role as the fatigue risk management lead, and she now meets with our PGY1s in boot camp and has done for the last couple of years, and met with the rest of the cohort through academic half day to complete the module that was developed through the University of Ottawa. She met with the residents a couple of different times, and I attended those town hall sessions with her to try to learn from them what things they felt would, what things were contributing to their fatigue and what things might be of benefit in terms of mitigating fatigue and mitigating risk. One of the things she was able to do was establish taxi vouchers for residents who felt they were too fatigued to drive after a call shift. And I think this went initially through the pediatrics department, but I think has been PGME-wide accepted now. I think some of them felt a little, the stress of people not knowing that my name was something that contributed overall to their wellness and fatigue. And so we put some posters up in different wards and all over the hospital to make people aware of who the residents were and what their names were. We have a couple of call rooms that are next to lounges in hallways, and so we put up some signs that made people aware that they were actually resident call sleep rooms. And that, believe it or not, has made a big difference to the amount of noise in the room. We also put fans or white noise machines in the call rooms to help mitigate some of the noise. And Dr. Chris Earle from psychiatry is coming to give a presentation on sleep hygiene later this year during the residents' academic half day. So just to reiterate, 20% of fatal collisions involve driver fatigue, and we're sending our residents home fatigued a lot of the time. Being awake for 24 hours is comparable to being legally impaired. And up to a third of all resident errors are deemed to have been caused by fatigue. So it is a significant risk and a significant problem. So that's it. I don't know if anybody has any questions. Got a few minutes despite my technical difficulty for questions.
Great. Thank you very much, Lynette. I think the last slide really summed things up. This one as well certainly can relate to that. So I'll just, put it out there. Any comments or questions, maybe even, I guess, Russell, if you had any comments as to what our program is currently doing, maybe just even a short summary about that for those who may not be aware.
Yeah, sure. Thanks, Vina. And thanks so much, Dr. Bose, for an excellent and important presentation. Of course, this is a topic that PGME widely has been taking more and more seriously, and family medicine included. So we're now using the University of Ottawa's module on fatigue risk management for part of our residence curriculum, in addition to lectures both on fatigue risk management and specifically on the hidden curriculum. We have the taxi vouchers, well, not vouchers, but reimbursement option for folks post-call, and are starting to use some self-report scales for residents to assess their fatigue levels prior to their roughly 3 times a year, really, meetings with their faculty advisors who can then kind of counsel them a bit more depending on what their levels of fatigue are reported at. So this is great because this presentation gives us all a bit more information for how to chat with our residents when they come in and are feeling quite fatigued. To the point that I was starting to make earlier as far as the hidden curriculum and culture goes, you know, I mean, there are, I recognize, so I think we often throw our hands up in the air or, you know, just say, well, it is what it is, when maybe there might be some good advice or strategies that we could take that we haven't stopped to think about. But also, even if a certain measure of fatigue is at some points needed or unavoidable, perhaps, under current contractual obligations, there's still the value of speaking to the issue in a constructive way, rather than you know, saying, well, you just got to get through it, and sweeping it under the hidden curriculum rug. And I think that yeah, I think our residents would benefit both from taking it seriously in conversations and from you know, our best efforts at advising and counseling them when they are fatigued. So I guess that's kind of where we are as a program now. Thanks, Vina, for inviting me to share the update, because I realize for some of you, you might have got that in our previous meeting, and for others, you might have just joined us now. Thanks.
Yeah, thank you very much, Russell. I think that's really helpful. Now I'll put it out to questions. We've got about 5-6 minutes left, or as I said, any comments about the presentation. It was an excellent presentation, and already getting questions about if we can have a copy of your slides and so on, which we can speak about later. So any comments or questions? Perhaps we're all a little fatigued today after a long weekend. Yeah, so I think, you know, there were many things highlighted in your presentation that I found really helpful, including the history and why we're calling our learners residents. I didn't know that, so thanks for that. And we all, having gone through training programs where call is expected, being up during the night is an expectation. I think, and so much has been learned. Thanks for reviewing the law in New York City. And I didn't realize that that had been. I knew there had been a bad outcome, but interesting to learn the history of when this all changed. So I think, and then bringing it full circle, talking about the hidden curriculum piece in this, because sometimes we do tend to minimize and say, oh, well, yeah, I did 1 and 3. It's okay. You'll be a better resident. If you're not around enough, you're not going to see enough. And so, a lot of this is continuing to this day. So this is really good, and for us to be checking in with ourselves as well, as to how we're interacting with our learners, and if we're propagating any of these myths, and to be mindful of our own behavior. So I think that there's been some thank yous there. And so any last minute questions or comments?
Wendy Graham has her hand up.
Oh, sorry. Thank you. I don't have the, you want to go ahead, Wendy? I don't have the full layout open.
Thanks so much. No, thanks for a great presentation. And I just not long back from the AMIE conference in Scotland, and a lot of talk there, panelists, about it was about like an inclusive learning environment. So different but related in terms of how we're stuck on we've always done it this way, and some really fabulous presentations, say from physicians who have significant disabilities, and how they needed their educational program to be somewhat different, and how it's just really time to be more inclusive from an EDI, anti-racism perspective, and working with people with disabilities and all kinds of other things. So I think it's relatable that we just need to just be a little bit more creative and reassess this notion of why we've always done what we've done, and how we can do better. So thanks so much.
Yeah, I actively try to not start any statement but with when I was a resident. For one thing, they don't care, right? Like, it doesn't register with the residents. As soon as you say it, they zone out because it is not relevant from their perspective. And it may or may not be, but most of the time it probably isn't. But I've had a lot of people say that, like, when they see the topic of fatigue risk management, they're just kind of rolling their eyes, and we did all this call, but after it's over, everyone is just like, wow, this is like concrete risk, and maybe we should just be thanking our lucky stars that we didn't cause more errors than we may have when we were fatigued as residents.
And I'll just finish off. I worked with an orthopedic resident many years ago who, after a call shift, went through an intersection and was in a really severe accident, and it was attributed to him not sleeping for 36 plus hours, and that was back in the 1980s. And so glad to see that things are changing, and we just have to continue to work on this.
Absolutely.
Hi, it's Heather. Just one last statement. Hi, Lynette. It's Heather Flynn. How are you?
Oh, hi, Heather. I'm good. Thank you.
Good. I think it's really important about the modeling of behavior, which is something that we all need to be reminded of. I mean, having been involved with so many wellness initiatives and things, if we're not modeling the behavior, then we're never going to be able to make our point, no matter how often we talk about it. So that's, become something that I've become more aware of. And I guess it's through these discussions that policy changes, because if we don't change the system, then nothing is ever going to change. Anyway, thanks, Lynette. It was really informative.
Oh, that's good. I know it's no good to teach residents to recognize their own fatigue if they don't feel safe to express it to staff that actually don't have an appreciation for the situation. So it really is on our shoulders to make this happen.
Okay, so that clues up the presentation for today. And again, thanks everyone for attending, and especially to Dr. Bose. It was very, very helpful, and we're so appreciative of you coming along and doing this presentation for us. We really appreciate it.
My pleasure.
Great. Bye. And I want to remind everyone as well that our next faculty development, as people are leaving, is going to be on December 5th. Okay, take care, everybody. Bye.